Alaikum everyone. Assalamu alaikum everyone. My name is Abdulaziz Alaklabi. I'm a third-year medical student, your colleague. And today we'll be covering CVP anatomy in relation to the OSPE specifically, also in the cardiovascular manner. So the pulmonary will be covered by someone else, inshallah. And before we get into this lecture or session, you could say, I want to explain how this is going to how we're going to cover this. Essentially, this is covering all of anatomy, specifically cardiovascular anatomy. And I'm going to pick certain points or emphasize on certain points that I believe are mainly related to OSPE. And please take this with a grain of salt, of course. You guys know what your doctors have said in the labs and whatever. And this is an additional resource you guys can use. And please make sure to stop me whenever you guys want to. You can unmute and ask any questions, and please don't hesitate to ask me questions. So, Bismillah. So to start off, the objectives we will be covering in this session is most importantly the anatomy of the heart, blood supply of the heart, which I believe is very important in relation to the OSPE specifically. A couple angiograms, and inshallah we'll give you a technique to understand angiograms, x-rays as well, and some questions, inshallah, a couple questions at the end. So to begin, of course, the heart, you guys all know. Also, by the way, guys, just to let you know, I want this to be an interactive session, so I like to ask questions. So please feel free to mute yourself, type the answer in the chat. But please, I want you guys to be interactive. I want this, instead of just hearing myself the whole time, I want this to be an interactive session. So right here, we say the heart is located in the mediastinum. So who can tell me what the borders of the mediastinum is? If anyone knows.
Anteriorly, the sternum, posteriorly, the thoracic vertebrae, and on either side, the lungs.
Perfect. Who was this?
Hazifah.
Excellent answer. Thank you. So you covered it perfectly. Of course, it's in the mediastinum, as you said, and it's obliquely in the chest. Okay, that's an important point as well to cover. So coverings of the heart is also called the pericardium. It is essentially a double-walled sac, and you have a superficial and deep portion. Superficial is a single fibrous covering, while deep is divided into two. We have visceral and parietal pericardium. So visceral pericardium is directly, another name for it is called the epicardium, is directly on the heart. Separated between the two is pericardial fluid, and then you have the parietal covering. Now a good diagram, I think you guys have seen this before, is a fist in a balloon. So the initial membrane covering your fist is the visceral pericardium, in other words, the epicardium. In between it is the air, which is the same as the pericardial fluid. And the outer membrane is the parietal pericardium. Sorry, Dana, what was your question? Is this not for OSPE? No, this is for OSPE. This is the anatomy portion of the OSPE. And we'll covering most points in general of this block in relation to cardiovascular anatomy. However, I will be emphasizing, when you will see, I'll be emphasizing on points that I think will be most important in relation to the OSPE. However, this is a general anatomy lecture, okay? Okay, perfect. So again, another picture of the heart and the pericardium. Now this right here is the epicardium, which is the visceral pericardium. And now this is directly on the heart, as you guys can see right here. Again, this is showing you actually the outer or the fibrous pericardium. Again, showing you the layers of the pericardium going from the outer, we said the superficial layer, which is a fibrous layer, and the deep layers, which are two, separated by pericardial fluid, the visceral and the parietal pericardium. Now there's no concepts behind here. This is just the arteries of the pericardium are from the internal mammary. You have to memorize this. Veins drain into the azygous veins. And the nerve supply is from the phrenic nerves. Now, this is very important. Now, this could come in the OSPE. They could show you a picture of the phrenic nerves and tell you what is the supply or what nerve is this. Now, you guys must know that. Again, showing you the different layers of the pericardium. Now, we know the heart is divided into 4 chambers, 2 upper atria and 2 lower ventricles for pumping of blood. Right side, of course, is non-oxygenated and left side is the oxygenated portion. Now the atria, they're receiving the chambers of blood they are receiving chambers of heart. So basically they receive blood, either deoxygenated or oxygenated. Now, initially the blood enters to the right atrium, deoxygenated through the superior and inferior vena cava, and then it enters the right ventricle, and then it goes to the pulmonary trunk. Pulmonary trunk divides into the 2 pulmonary arteries to go to the lungs to be oxygenated, and will return through the pulmonary veins into the left atrium. So now we have deoxygenated blood, sorry. And this will enter the left atrium and will fill into the left ventricle. And of course, the left ventricle, as you know, will pump this into the aorta, which will supply the entire body with the oxygenated blood. Now, surface of the heart, very, very basic concept. There's an anterior surface, also called sternocostal surface because it's against the sternum. You have a posterior surface, which is important to understand, that is mainly compromised by the left atrium. That is a very important concept. As well as an inferior surface, which is mainly compromised by the ventricles. As you guys can see here, the posterior surface, also called the base, where you can see the left atrium. Can you guys see my cursor, by the way? Okay, great. So we said the posterior surface, which we can see right here, is made of the left atrium, and then the inferior or diaphragmatic surface, which is laying on the diaphragm, made up by the 2 ventricles. Sulci, they're grooves in the heart, and they contain the blood vessels of the heart, of course, the coronary blood vessels. Now, over here, we see there's something called the posterior interventricular sulcus. Now, this we'll be learning. It contains, what artery does it contain? The posterior interventricular sulcus, you guys know.
Pia.
Pia, great. And does anyone know the vein that drains through this posterior interventricular sulcus?
Middle cardiac vein.
The middle cardiac vein, great. So you guys understand this concept very well, I think so. And of course, there's the anterior sulcus and the posterior sulcus, as we said. Now we have, again, borders of the heart. The right border is made up by the right atrium, as you can see right here. The right atrium makes the right border. Now the inferior border, as we say, is on the diaphragm, as we showed you before, made up mainly by the right ventricle and a slight portion of the left ventricle, as we see here, and a slight portion of the right ventricle, right atrium, sorry. So mainly by the right ventricle. And the left border of the heart, of course, is made up by the left ventricle and a little bit of the left auricle. Now, the pericardial sinuses, okay? So we have 2 major sinuses, the transverse pericardial sinus and the oblique pericardial sinus. But this is very important to understand their location because they can definitely bring you a picture of a model and pinpoint exactly what they will show you, basically an arrow pointing at a sinus, and you must know which sinus it is. So the transverse sinus we can see here is between the visceral pericardium covering the aorta and pulmonary trunk. So you can see right here, this is the transverse sinus. Now the oblique pericardial sinus is behind the heart, okay? and also again between the visceral pericardium covering the base of the heart. Now we can see cadaver pictures over here. Now they can bring you a picture like this, asking you what is a structure they are pointing at or the probe is going through. Now we know this is behind the aorta and the pulmonary trunk. So what is this? What sinus?
Transverse.
Transverse sinus. Okay. So you guys must know this. The transverse versus oblique sinus. This can definitely come on your OSPE. Now over here it's asking you what sinus are they pointing at? What is the hand, the placement of the hand?
Oblique.
Oblique sinus, correct, guys. Nice. Now, from the slide, I don't want you guys to, go deeply into the slide. However, some important features I want you guys to understand is this anatomical area right here. Does anyone know what this is called?
The neurosternal joint.
Angle of Louis.
Okay.
Angle of Louis.
Yes, you're correct. Whoever said sternal joint, yes, you're right. But I was looking for the name of the line. Yes, correct. So you guys said angle of Louis. And it corresponds, of course, to the second rib. And below that is the second intercostal space, of course. Now, why is this significant? Does anyone know why this is significant? Okay, yes, it helps in
It's
locating
an
the ribs.
important landmark to locate the ribs.
Okay, that's correct, yes. Locating the number of the ribs or the position, you could say. Great job, Wade. To locate the auscultation sites. Now, everyone's correct. You can definitely use this to locate ribs, which number you're looking at, which one you're, palpating, you could say. But specifically, it's a great anatomical point to help pinpoint where exactly to auscultate for specific valves. We're going to learn that in the next slides. Now, so again, this is the angle of Louis. And we use this mainly to help us locate different auscultation points, okay? So this is, I think, the most important auscultation point. I think we're going to cover the rest ones in upcoming slides. However, in the mid-clavicular line and the fifth intercostal space, you could say, if you auscultate at this area, you will be hearing the mitral valve, okay? The mitral valve at the mid-clavicular line corresponding with the fifth intercostal space. Now this gives rise to the sound that we said is a mitral valve. Now, does anyone know why exactly we listen at this point? Because that's not exactly where that mitral valve is located. Because if you guys can see from the heart over here, the mitral valve is located upper over here. But why are we listening at the fifth intercostal space? Does anyone know the physiology behind this? Great job, Shahad. So if you guys saw what Shahad said, it's the blood rushing. So it's not the sound of the actual valve. It's when the valve opens, the blood is rushing and hitting the ventricle wall. And the closest place that we can hear this is at the fifth intercostal space. So if you can see from my cursor, the mitral valve is portioned here between the left atrium and the left ventricle. As blood is rushing in, it is going to be hitting the wall of the left ventricle. Now, when this happens, the closest area we can listen or hear the sound is at the fifth intercostal space at the mid-clavicular line. So this is a very important anatomical area of auscultation. Now, another point behind this is that if you do not hear it at the mid-clavicular line and it's displaced, this essentially means that the heart is undergoing or has undergone cardiomegaly or enlarged, okay? So the enlarged heart would have a displaced or apex beat. But I don't think this is very extremely significant. As long as you guys know the landmark, the fifth intercostal space at the mid-clavicular line, I think you guys would be okay. Now, the other points of auscultation This right here is the second intercostal space just adjacent to the sternum. So we said for the mitral valve, we go at the midclavicular line. However, for the aorta and the pulmonary valve, we go just adjacently to the sternum. So this is the second intercostal space on the right, adjacent to the sternum, sorry. And the pulmonary valve, we listen to it on the left, second intercostal space, just adjacent to the sternum. The tricuspid valve, we hear it in the fifth or fourth, either one is correct, fourth intercostal space, just adjacent on the left side, sorry, just adjacent to the sternum. Okay. Is anyone confused to the points of auscultation? So it's not the turbulence exactly. It's the essentially the rushing of blood and the hitting of the blood to whatever closest wall is present. So for example, the aortic valve, we can see here, the present aortic valve is this structure right here. However, we listen to it on the right side when it's actually closer to the left. The reason being is that the left ventricle will be pumping blood through this valve and it will hit the left side, you could say, or the right side, sorry, of the aorta. The closest point we can hear this hitting of blood, you could say, is the right second intercostal space. So it's the closest point where you can hear the rushing of blood or hitting of blood towards the closest membrane or structure. So for the pulmonary valve, it's the right ventricle pumping through the pulmonary valve to the pulmonary trunk. Now, the closest point we can hear this is the left second intercostal space. Same thing going with the tricuspid valve. So the right atrium is pumping blood into the right ventricle. And as this happens, the blood is rushing and hitting the right ventricle at this area. So this is the way we listen to points of auscultation and listen to different heart valves. Okay, so heart valves, very simple concept. There's two types of valves, as you guys know, AV valves and semilunar valves. Okay, and from their name, you can describe already main points from them. So atrioventricular valves helps you in the anatomical, point of location. It's between the atrium and the ventricles. And the semilunar valves are between the ventricles and the corresponding structures, whether that be the aorta in the case of the aortic valve and the pulmonary trunk in the case of the pulmonary valve. Now, an important concept is the opening and closing of valves. Now, opening of valves is extremely simple. It says that there is increased pressure in either the atrium or the ventricles corresponding to the valve that is opening. So in the case of the AV valves, the atrium have to have an increased pressure than the ventricles. So the atrium have to have more pressure than the ventricles, and blood will rush into the ventricles, pushing the cusps of the valves towards the away from the opening, you could say, of the ventricles. Now, these cusps are very important and are connected to these two structures right here. We can see these are the papillary muscles, and they're connected through what we call chordae tendineae. And as you can see here, they are relaxed. And this is in a state of opening, an open valve. The chordae tendineae are relaxed, and so are the papillary muscles. And this allows blood to enter from the atrium into the ventricles. Now, once the ventricles have filled, the ventricles will start contracting, correct? And when the ventricles start contracting, they will be pushing against the cusps, causing them to close. However, if there was no papillary muscles, they will be eversed. There will be eversion of the valves. So the function of the papillary muscles is to prevent eversion of the AV valves. This is very important. So the blood is entering into the ventricles, and once it fills up and is starting to contract, the cusps will be prevented from everting or causing eversion and re-entry or regurgitation of blood by the action of the papillary muscles over here through the coronary tendon. So you can see right here the picture. The cusps are away from the valve as the blood is entering into the ventricles. And you can see the coronary tendon are slack and the papillary muscles are relaxed. And once the ventricles start to pump blood into the pulmonary trunk or the aorta, the papillary muscles will be contracted to prevent the eversion of the AV valves. Does everyone understand this concept? Well, this is a picture of the mitral valve where we can see in a closed manner, where you can see you don't really get the closure. Okay, so essentially, Sidra, the ventricles will start contracting after they have filled them with blood. They will start contracting into the aorta. Okay, you can see it right here, into the aorta. Now they will fill in these cusps, causing them, they were before in a relaxed manner. They will fill in these cusps and cause them to rise. However, if there was no other mechanism, they will just everse and they will regurgitate. However, the function of the papillary muscles is to, remain or hold the cusps in place and prevent eversion of these valves. Did you understand that? Okay, great. Now, the semilunar valves, okay, are between the ventricles and the aorta or pulmonary trunk. They open with ventricular contraction, and they, of course, close with relaxation. Now, I want someone to answer me a question. How can we identify whether this is the aortic or pulmonary valves without of course, it's saying here aortic sinus?
The aortic valve has the opening for the coronary arteries posterior to the right and left cusps.
Okay, so you said the orientation, no, the opening of the coronary arteries. What is the second point? That is one point of differentiation.
Also the
orientation of the
cusps.
What is the difference in orientation?
In pulmonary, it has anterior, and the aortic it has the posterior.
Correct. So 2 points of differentiation, as your friend Rayan said. The initially, you can see right here the openings of the 2 coronary arteries, the right and left coronary arteries, as well as the orientation of the cusps. So both aortic and pulmonary valves have 3 cusps. However, the orientation is different. As you can see here, the aortic valve has left, right, and posterior cusps, while the pulmonary has right, left, and anterior. This is an important concept that you guys have to get. And sorry, whoever answered in the chat, I didn't see the chat, so good job answering that. Now, so the valves in general, they need something to attach to. And this right here is the cardiac skeleton, is within the myocardium. Now, you could ask, why does the valves not just connect to the myocardium itself? The reason being is because it needs an anchorage through which the valves will not become relaxed or open with time, because the myocardium is contracting with time. And eventually, if the valves were attached to the myocardium, they will eventually open and be more relaxed, in a more relaxed state. However, in this state, you can see the blue lines. the valves are attached to a fibroskeleton, and this allows it to be anchored and prevent any relaxation of these valves. Now, internal features of the four different chambers. So we're going to start off with the right atrium. So the right atrium receives blood from 3 vessels. Okay. Okay, I mean, I'll repeat the cardiac skeleton. Okay. So it's a very basic concept, nothing more than the valves have to have an anchorage to prevent any they have to have a great anchorage for functioning and preventing opening or with a relaxation, you will have weak valves and there will be regurgitation of blood. Okay, so the valves themselves have to have an anchorage point that will not be moving. Did that answer your question, Amina? So essentially, the cardiac skeleton is there for anchoring of the valves. Okay, great. The right atrium, no problem, Amina. So the right atrium, okay? The right atrium receives blood from 3 structures, okay? The superior vena cava, the inferior vena cava, and this structure right here. So what is this structure right here? Does anyone know?
Coronary sinus.
Correct, the coronary sinus. So the blood, of course, has veins and will just fill into the right atrium directly. There's no need for any other vessels. It will drain directly into the right atrium. This structure right here, the fossa ovalis. What is the significance of the fossa ovalis? Does anyone know? Does anyone know what the, okay, let me see the chat. Okay, fetal blood. Okay, what do you mean by fetal blood? I want more specific answer. Okay, correct. So everyone's getting it right. So it's an important feature in fetal blood to allow the oxygenated blood to reach the aorta directly. And this allows for 75% of the blood to reach the aorta directly from the atrium. Now, normally, of course, it will essentially close and now become the fossa ovalis. However, if it stays open, it's called the atrial septal defect, where the septum in between the atrium have a defect, which is the patent fossa ovalis, sorry. And over here, we can see that the posterior wall of the right atrium is smooth and the anterior wall is made of these pectinate muscles, okay? This rough pectinate muscles. And in between it, we have something called the crista terminalis. Now, these are all just anatomical landmarks that you have to familiarize yourself with. Okay. Now, as you guys answered before, it's a very important structure, the foramen ovale in fetal circulation. It is what you call the first bypass. So you can see here the umbilical vein, which is receiving blood from the mother, which is in the oxygenated fashion, therefore does not need to go to the lungs. The fetal blood does not need to go to the lungs. Therefore, it can bypass the right side of the heart through the foramen ovale into the left side of the heart, into the left atrium, to the left ventricle, and directly to the aorta. And the aorta, of course, pumps blood to the rest of the body. Now, this mechanism covers for 75% of the circulation. However, the 25% will continue from the right atrium into the right ventricle and into the pulmonary trunk. However, there's a second bypass method where the rest of this 25% of blood will go through from the pulmonary trunk into what is called the ductus arteriosus, okay? And will go through the pulmonary trunk into the aorta. And this is how the entirety of the fetal circulation will bypass the lung in general. Okay, great job, Asil, answering the question before me. So the crista terminalis is just an anatomical structure. It divides or separates the smooth part of the right atrium and the muscular part, as well as your colleague Asil said, the superior portion of the crista terminalis. Adjacent to it is the location of the SA node. Now, as you know, SA node is not visible on in a cadaver. Of course, you can't just open up a cadaver and see the SA node. It is a microscopic structure. So the location of it is, as we know, adjacent to the superior portion of the crista terminalis. Did that answer your question, Amina? Did you understand that point? Okay, great. And of course, again, the second bypass mechanism should also close and become the ligamentum arteriosum as well. Okay. Now, this I think is very important for your OSPE, is the fact that this structure, does anyone know what nerve this is, first and foremost? What nerve this is I'm pointing at?
Laryngeal nerve.
The one I'm pointing at my cursor.
Vagus.
The vagus, okay, correct. So you guys understand that this is the vagus nerve going down over the aorta, and we'll give this branch the left recurrent laryngeal nerve. So this right here is a branch of the vagus. However, when anyone asks you what is this structure that I'm pointing at this moment, this is the vagus nerve. The vagus nerve will give a branch, which is the left recurrent laryngeal nerve, which will go under the ligamentum arteriosum and under the aorta, and will ascend, of course, superiorly to supply the larynx and other structures. However, this is a very important structure because it's in close relation with the aorta and the ligamentum arteriosum. So they can definitely ask you this question on OSPE. Okay. Now, internal features of the right ventricle, okay? So first and foremost, we can see the smooth part of the ventricle is very minimal. We saw in the right atrium, there was a posterior smooth part and anterior a muscular part, you could say. Over here, it is mainly muscular, and it's called the trabecula carne, okay? As well, we can see these three papillary muscles. We can see anterior, posterior, and septal, okay? Papillary muscles. So these two are anterior. This is a posterior papillary, and this is septal. So there's three papillary muscles present in the ventricles: anterior portion, posterior portion, and a septal portion, all in accordance with the three cusps of the tricuspid valve. Okay. And we can see here, there's a structure right here called the moderator band. Now this moderator band, all it does is connect the septum, the interventricular septum, with the papillary muscles. It has some conduction fibers, but other than that, it's just an anatomical structure. Over here, we can see the smooth part of the right ventricle, okay? This is called the infundibulum or the conus arteriosus. Now, this is just for pumping of blood, of course. It just allows for ease of passage of blood through the right ventricle into the pulmonary trunk. Okay. Now, over here, we can see the right atrium and the right ventricle. Left atrium and left ventricle. And we can see it's much simpler. In the left atrium, it's mainly just smooth, and we can see, of course, the remnants of the foramen ovale. And then in the left ventricle, a main finding, or most important finding, is this thick muscular wall, okay? Which is 3 times as thick as the right ventricle, okay? This is very important. And the reason for this is because of course, the left ventricle has to pump blood through the aorta to the entire body through an increased pressure system, a higher pressure system. Therefore, it needs increased muscular activity to pump all this blood against this gradient of pressure. Now we can see this again, as I said before, the left ventricle is 3 times as thick. We can see right here, there's anterior and posterior papillary muscles. Remember how we said there was anterior, posterior, and septal in the right ventricle? Here, there is only 2. Can anyone explain why there's only 2?
Because it's bicuspid.
Correct. So of course, it's a bicuspid valve or mitral valve, meaning it only needs 2 pairs of papillary muscles instead of the tricuspid valve, which needed 3. We can see as well the coronae tendineae, of course, anchoring the cusps and attaching them to the papillary muscles. And yeah, I think we covered everything in the slide. And this smooth part of the left ventricle is called the aortic vestibule. And we called it something else in the right ventricle. Does anyone remember what the name was? The infundibulum. Sorry, I thought you were gonna. I didn't think anyone was gonna answer. So the infundibulum was what we call the smooth part of the right ventricle, and the left ventricle we call it the aortic vestibule. Okay. Now the interventricular septum. It is made up of mainly a muscular portion. However, there is a single centimeter long portion that is made of the membranous, a membranous part of the IV septum. And this is very important in ventricular septal defect. It is the most commonly affected site of the interventricular septum in VSD. Now, I think we've explained this before. Actually, the first heart sound, we have to differentiate. There's 2 heart sounds we call lub-dub. The lub is the sound of the closure of the AV valves, and the dub sound is the closure of the semilunar valves. Now, Dr. Akif sometimes likes to ask these questions. So it might not be OSPE, but it may be MCQ. Again, this is the location of the auscultation for the valves, as we've already talked about. Again, same concept. Now, again, this is just a recap because we're going to talk about the coronary blood vessels. This is the aortic sinuses, as we see before. And essentially, when the ventricles relax, the closure of this valve is through filling of the cusps. So when the ventricles contract and the blood gushes into the aorta, the cusp will be situated away from the middle. And when the ventricles relax due to negative pressure, as the blood is falling back, it will fill in these cusps, and these cusps will then close the valve. They will come together and close the valve. Now, as they fill, we can see here these 2 openings. These openings are for the coronary arteries. So the first organ that the heart essentially gives blood to is the heart. So through these openings, it will give blood to the coronary blood vessels. Now we're going to start off with the left coronary artery. So the left coronary artery is giving rise to 2 main arteries, as you guys know. The anterior interventricular artery, as we like to call it, LAD, left anterior descending artery. And we said this before, it goes to the anterior interventricular sulcus, okay? The anterior interventricular sulcus, and supplying mainly the left ventricle and 2/3 of the interventricular septum. This is very important. So it supplies 2/3 of the IV septum and actually wraps around behind and will connect with another artery we talked about before, which was PIA. So the LAD will supply 2/3 of the interventricular septum. The second branch of the left coronary is the circumflex branch, okay? And the circumflex branch gives a minor artery, which is the left marginal artery, supplying the left border of the heart, somewhat the rest of the left ventricle, you would say. And the circumflex will wrap around and will anastomose with other blood vessels, as we will see. Now we explain this, the LAD gives us also some diagonal branches, as you see, diagonal branches which will supply, of course, the left ventricle. And as we said, the circumflex artery, it gives branches to the left atrium as well. And it runs very specifically in the coronary sulcus. We're going to talk about this. I'm going to show you a picture. So we can see right here, the left coronary artery, if you can see, it will wrap around, as you see from this picture, as you can see, follow my cursor, it will wrap around and go through here. See the circumflex right here, the labeled branch, circumflex branch. So it is going through this sulcus right here, which is the coronary sulcus. And it gives us, as we said, the left marginal artery. It gives off the left marginal artery. So now we're going to talk about the right coronary artery. The right coronary artery initially gives off what we call SA nodal branches, okay? We're going to see this actually happens in 60% of people. The right coronary artery will give branches to the SA node, as well as the AV node. And the first major branch that it gives off is what we call the right marginal artery, and will go all the way until the apex, and will supply majority of the right ventricle. Now, this picture right here, the reason I give this to you guys is more of a concept method, because as you see in angiograms are kind of confusing because of one reason. They're giving you a 2D image for a 3-dimensional object. So the heart is 3-dimensional, of course, and the blood vessels are, of course, running along the surface of the heart. However, when you take an image or an angiogram, you don't see the heart, of course. All you see is the branches. So it appears as a 2-dimensional image. So I want this to be very clear. So we can see right here the left main artery. So we can see the LAD. If we look at it from this angle, the LAD is going to be coming off in a superior fashion. So if we took out the heart and we just saw it without only the blood vessels, we would see LAD in the uppermost fashion. And the left circumflex, which usually wraps around, as we said, and goes through the coronary sulcus, will appear as it's going downwards directly, when in reality, it is because it's a 3-dimensional object, it is wrapping around. However, in the angiogram, it appears as it's going directly, inferior, you could say. So we see in this picture, this is the left coronary artery, and this is the LAD. This is a very important concept. I hope you guys are grasping it. And the left circumflex is over here. So as we said, it's a 3-dimensional object. Please try to picture the heart as a 3-dimensional object and where the arteries are going, because I understand this can be difficult. Can you guys understand this? Okay, great. If anyone didn't understand this point, I'm happy to repeat. Okay, great, Hiba. So Hiba, they're gonna ask you potentially, and not always, about an angiogram. They love to always ask about the LAD, and of course, what happens if it's blocked, for example, and you have loss of course, blood supply to the, as we said, the anterior 2/3 of the IV septum. So that's why I wanted to, clarify the angiogram and make it as clear as possible. So looking at this picture, it is a 2-dimensional image. You can't really understand the orientation of the heart unless they told you exactly where it is. So we can see the left coronary artery. However, of course, from your images, you would think that because this is moving inferiorly, you would think this is the LAD, which I understand why it's confusing. However, the orientation of the heart is laterally. This is a lateral image. If you can see from here, go back to the previous image. We're looking at the heart from a lateral view, which is most angiograms. From a lateral view, the LAD is going to be moving anteriorly, of course, as we know. But because we're looking at it laterally, it is looking as if it's moving anteriorly or most superficially. And the left circumflex, which moves laterally, as you're looking at it laterally, it looks like it's descending or going inferiorly. So this is the concept behind this. So the left circumflex, as it's wrapping around the heart, in a lateral angiogram, it'll look as if it is going inferiorly. However, it is not in actuality. However, the image will show it in this manner. Did that answer your question, Noor? How do we know if it's a lateral view to identify if it's LAD or left circumflex? I hope they don't overcomplicate this question if it comes, and it might not even come. However, in most cases, in almost all cases, they will give you this image, which is the most common orientation of the angiogram, hopefully, from my experience. However, you can study the different angles depending on if the doctor has told you to study them. However, I think this is more than sufficient. And you said, how do we know if it's lateral or anterior from the angiogram? You cannot. Honestly, you cannot. The radiologist would usually tell you that this is a lateral angiogram or an anterior angiogram or whatever dimension or direction he took the angiogram in. And from there, of course, you can identify the arteries in accordance. Hope this answers your question. So see, this is an anterior, again, left lateral actually X-ray. However, this is more complicated. It's from the left side. They usually ask it from the right side, which is the most common. So I just wanted to show you guys another picture of it. So please don't be confused in an example to orientation. They will tell you the orientation. And please remember which one's anterior and which one's wrapping around. So we can see right here, this is from the left side. So this right here is the left coronary artery. It's giving off the LAD. It's going anteriorly. However, we can see it's the opposite in the other picture. It was going towards the right section, but however, it's because we're looking from the right, okay? I hope this was very clear. Please, if anyone had a question, you guys can stop me again. Okay, great. So yes, 9 is the circumflex, correct. Continuing off, we talked already about the PI, I think. It goes through, it's a branch of the right coronary artery, and it goes into the posterior interventricular sulcus. Noor Wasim, what about the marginal? Could you clarify your question, Noor? I didn't understand your question. And the no, you will never have to identify the marginal. I guarantee you. Just focus on the LAD and the left circumflex. Inshallah, you'll be perfectly fine. Okay. So again, so the right coronary artery will give off, as we said, the right marginal branch first and foremost, which will supply the right ventricle, and will wrap around, okay, again through the coronary sulcus, and we'll give off this branch, as we know as PIA or PDA, the posterior descending artery, which goes into the posterior interventricular sulcus. Okay. And again, this supplies the posterior 1/3 of the IV septum. This is a very, very important concept. The LAD, as we said, it supplies the anterior 2/3 of the IV septum, and the PDA supplies the posterior 1/3 of the interventricular septum. Now, can anyone explain to me what dominance means? Right dominance, left dominance. Can anyone explain that?
It is basically where PIA comes from.
So where PIA comes from. Great. Why is it significant?
Blood supplied to the interventricular septum.
Okay, correct. So in case of blockage, but even more specifically, why does it matter? If it was, so what if it's blocked?
Because if the person was left dominant and there was an obstruction of the left coronary artery, there would be total ischemia in the septum.
MashaAllah, Rayyan, answering all the questions. Correct. So as we said, there's a right and left dominance depending on where the PIA originates from. Now the significance from this is if the PIA originates from the left coronary artery, that means the entire IV septum, because remember that we said the LAD supplies the anterior 2/3, PIA supplies the posterior 1/3. So if they both come from the left coronary artery and the left coronary artery is blocked, that means the entire blood supply of the IV septum is gone. There's going to be total ischemia. However, if the, let's say the right coronary artery is blocked, and PIA, of course, will be blocked, the LAD will compensate, and there will still be, ischemia, of course, but it will be definitely less than if there was a complete obstruction in the case of the left coronary dominance. And codominance is very uncommon. However, both arteries supply the PIA essentially. Okay, so the veins or sulci of the we already talked about sulci, the veins of the heart. We talked about this vein right here, which is the middle cardiac vein. And of course, all veins drain into this structure right here. Does anyone know what the structure is called?
Coronary sinus.
Coronary sinus, okay. And of course, we said already that the coronary sinus drains directly into the right atrium. So all veins, except a few we'll see, drain into the coronary sinus, okay? So there's three major veins: the great cardiac vein running along with the LAD, the middle cardiac vein running along with PIA, and the small cardiac vein which runs along with the right marginal artery, okay? Now, those are almost all veins drain into the coronary sinus, which drains directly into the right atrium. However, there are some small veins right here, the anterior cardiac veins and the least cardiac veins, which drain, all you need to know is that they drain directly into the right atrium, nothing more, nothing less. Now, for X-rays, all you need to know is major identification of landmarks or any major locations of structures involving the cardiovascular system, okay? So I like to start from the right side and then move on to the left side. So initially, the most inferior object which we cannot see is the inferior vena cava. The inferior vena cava gives off a slight indentation, you could say. This slight indentation of the inferior vena cava, as we go up, will then drain into what structure? The right atrium. So this bulge right here is the bulge created from the right atrium. And as we move along more superiorly, this will be the alignment with the superior vena cava. And another very important landmark is this little notch right here. Now, can anyone tell me the significance or the reason we have this notch? Correct. It's the azygous vein. The azygous vein will be draining at this point. Therefore, it comes and loops. This is not a topic of my discussion. However, this is the location or the indentation of the arch of the azygous vein. Okay. And then we go from the left side. Now, this major, you could say, knuckle, as they would call it, is the indentation created by the arch of aorta. They love to ask this question, along with the arch of azygous vein. You need to know all notches and all knuckles created by different vessels and different chambers of the heart. And this minor indentation is made up by the main pulmonary artery. Okay. You want me to repeat it from the very beginning? Okay, sure. So let me just use this. So I want to just make this very clear, okay? So this is a structure of the heart. This is the entirety of the heart from here to here. Inferiorly, we're going to have the IVC draining into, of course, this structure right here. This is the location of the right atrium. Now, the IVC is going to create this indentation right here. This little indentation we see, this is caused by the IVC, okay? And over here, we have this bulge. We can see this bulge. This is caused by the right atrium. So the IVC is draining into the right atrium, and the right atrium is causing this bulge on the right lung that we can see on X-ray. The superior vena cava, it's not much of a bulge. It's just this is just a line right showing the location of the SVC. However, it will be in this fashion. Okay. The arch of azygous vein is the vein. Basically, it drains in this area. Okay. So it will be going up essentially. It is in the posterior mediastinum, as you guys know, and will be coming up in an upwards fashion. It will drain directly into the vein corresponding to its drainage. Over here, this is the arch of aorta. It causes basically a knuckle. We can see here a very important knuckle and a very important anatomical landmark that we can see. So essentially, we can kind of create an image that will help you, understand it. So if we said this is the SVC, this is the right atrium, and let's say this is the line of the interventricular septum. And this is the pulmonary trunk, okay? And this is the left ventricle draining into the aorta, as we know. The aorta, as we know, is an arch, has an arch, and the arch will be coming up in this manner and will be going, as you guys know, in this manner and will be descending. So there's an ascending portion and descending portion. And now this arch of aorta will be creating this indentation on the X-ray. Now that's all it is. It's just indentations. This is all you need to know. And of course, this is the major pulmonary artery causing this type of small indentation. I don't think they ever asked this, but it's good to know it. The auricle of the left atrium, also you should know this. And of course, the left border of the heart we know is the left ventricle. So of course, this portion of the X-ray is made up or bordered by the left ventricle. Now, I hope this was very clear. Did everyone understand this point? Okay, great. Well, this is too complex. This is more than enough. Know these landmarks and inshallah, you'll be okay. Maybe just the claustrophrenic angle. I think you guys definitely have to know this. You guys have learned this. The claustrophrenic angle is an important feature when you see the person who'll be covering, inshallah, pulmonary anatomy for OSPE. Of course, we will talk about hemothorax and whatnot, and how there's going to be a loss of claustrophrenic angle. So just keep in mind with that important feature. However, this is more than enough for the cardiovascular or main portion of X-rays. So alhamdulillah, we have covered all aspects of cardiovascular anatomy. So now we're going to be covering some questions, okay? So I want you guys to write in the chat. I don't want anyone to open their mic, so then we can all see everyone answer. So please answer. The first question is, name the artery in yellow. And the second question, B, was not covered in this lecture, but inshallah, I'll be able to explain it. So first of all, I want everyone to be able to answer question A, okay? Can you please tell an easy way to identify a PA versus AP? Okay, sure. I will answer that question right after this. Okay, guys, this is the LAD. Okay, this is not circumflex. Please remember the order of and the X-ray, remember it was a two-dimensional structure. This right here, this structure right here is the left circumflex. Now, this structure is the LAD. If you remember, we said it's a three-dimensional object, which is the heart. However, this is a two-dimensional image given from a lateral point of view. Therefore, I understand how confusing it is. However, look at the most anterior aspect, and the anterior portion, or the most right portion, is the LAD, and the structure moving directly inferior is the left circumflex. Please, did everyone understand this concept? I know it's very confusing. Okay, great. And patient feels pain on his left upper limb medially. This pain is due to what? What is the name of this pain also, by the way?
Angina.
Angina, okay. And referred pain, correct. And does anyone know the nerve, the specific nerve that causes this referred pain? Okay, you guys are completely correct. T1 to T4. You guys may not have learned this. I don't know if you guys learned this, but T1 to T4 is a great answer. However, sometimes Dr. Atif likes to know the exact nerve. It's the intercostal brachial nerve, okay? So it's just a complete memorized concept that you guys have to know. You guys are all correct. Whoever said T1, T4, that is completely correct. However, the actual nerve that is taking the sensations from T1 to T4 is the intercostal brachial nerve, which allows the sensation to be, in the anginal manner. Okay. Now, I remember someone had a question about, can someone explain the difference between AP or PA? Sure. Okay. So PA versus AP. Okay, so I want you guys to notice main points, okay, in regards to AP versus PA. What I look for specifically is two things. Of course, I know from your lectures are more than that. However, is of course, the size of the heart in relation to the total length, as well as the presence of scapular lines. If you guys see from here, I see no scapular lines. I will, inshallah, in a second, I'll pull up some AP views. However, this is PA because I do not see any scapular lines, indicating the scapula is out of range from this picture, as well as the fact that the cardiac silhouette is less than half of the total diameter. So these are two identification points, you could say, for differentiation between PA and AP. Does anyone know any other points from your lectures maybe that you could help your colleague with? I don't think this is a very important thing, but potentially you will be. I don't know from my scope if you guys will. I don't remember having a question in regards to AP versus PA. And Mehdi, your question is vertebra seen in AP? Usually the vertebrae, as you can see, are very aslan, minimally seen. However, they are seen in AP, but very minimally. So you could say that is a differentiating factor. You're correct. And Shahad, you said another point, the clavicle. That's very correct. The clavicle is going in a different fashion. You see right here, the clavicle is in a downwards fashion. This is because it's a PA view. However, in an AP view, the clavicle will be directly horizontal or almost in an upward fashion. Okay. So the person who asked this question, I hope that answered your question. Okay, great. Now, I know this is not the scope of my lecture or session, but inshallah, you guys have done this before. please remember that I did not have the ability to obtain questions specifically for this session because I covered a lot of topics. However, if you guys notice any questions or have any questions, I will be sending my number or my email to you guys. So just in case you guys have any more questions after this session, you guys can feel free to contact me. So let's begin with this question. Can you guys label structures 32, 32, 33, 26, and 19? So 33 right here, 32, 26, and 19. Okay. I want someone to unmute and answer this question.
Number 33 is the superior vena cava. Number 32 is ascending aorta. Number 26 is the pulmonary trunk. Number 18 is the azygous vein.
It's 19, but yeah, you're right. It's the azygous
yeah,
vein.
19. Yeah.
And what's her name? Sorry.
Ghaida.
Ghaida. Okay. Can you please answer also the second question if you can?
Okay, is this scan below or after T4? It's after T4 because of the fact that we have the bifurcation of the trachea in number 24 and number 23.
Great job, Ghaida.
They,
Great job.
Yeah, thank you.
Okay, so that was the answers to the question. So as we said, SVC is number 33, 32 is the aorta, 26 is the pulmonary trunk, number 19 is the azygous vein. And the second question is this a CT scan below or after T4? As your colleague Ghaida said, it's below T4 because the trachea has already bifurcated. Okay, so that covers my entire session. Does anyone have any final questions, any concerns?
Yeah, I have a question.
Go ahead.
How do we differentiate between the vagus nerve and the phrenic nerve on a cadaver?
Say it again, sorry.
How
The
do we
vagus nerve
differentiate
and
between
phrenic?
the vagus and the phrenic, yeah, on a cadaver?
I really wish I had a picture for this. However, the phrenic nerve is much more posteriorly, okay? Let me picture this. Rayan is your name, right? Let me get you, I will give you guys my email. And please send me an email and I'll send you a picture regarding this and a small explanation, okay? Because I just don't have the picture with me, okay?
Of course, thank you so much.
No problem. So no problem, everyone. So I'm gonna write my email in the chat right now. If anyone has any further questions, any concerns, don't hesitate to email me. Okay, assalamu alaikum, everyone. Thank you so much. Any more concerns, any more questions, feel free to email me. If Hamza is still here, do I just... Okay, good. So you will stop the recording?
Yeah.